Good afternoon, and thanks for joining us for today's Healthline 3 conversation. I'm Courtney Butts. Dr. Joseph Golden joins us today from Willis-Knighton Cardiology Bossier. Thanks for joining us, Doctor.
Thank you. I'm happy to be here.
Absolutely. So you are a cardiologist. This is kind of a specialty within medicine. So you have specialized training with the heart and all the things with the cardiovascular system. But tell us a little bit about what you do as a cardiologist.
Right. So we see basically all heart conditions, right? So that includes blood pressure. That's part of our cardiovascular system. So blood pressure, heart failure, coronary artery disease. Those are the heart attacks and heart blockages, plaque buildup that we have, and then basically cholesterol trouble and some other stuff like that.
Yeah.
I'm also an interventional cardiologist, so I do procedures as well. It involves coronary stents and those type of things.
Right, yes, and Willis-Knighton has a pretty, is it structural heart clinic? Is that interventional
yeah, so,
kind of?
Right, that's another subspecialty of interventional. Yeah, it gets pretty complicated pretty quickly. But
okay.
Yeah, so I don't do the structural side of things, like TAVRs or Watchman, those type of procedures.
Gotcha. Well, very interesting. So you cover a lot of different things within. I feel like a lot of times we just think about heart attacks, which is what we'll be talking about today, but there's a lot of other things that you can do to maybe help even preventing someone from getting to that point or managing their current disease state.
Yeah, exactly. The goal for any visit is hopefully preventing future things. So that's always why it's good to see your primary care doctor. You want to prevent the heart attack, not, deal with it after. So
absolutely, yes. And so what we are talking about today is heart health essentials, recognizing heart attack symptoms and reducing those risk factors. So we, maybe it's a good place to start with talking about the risk factors, the big ones that people should watch out for, and maybe there's modifiable and I'm sure non-modifiable. Right. So kind of take me through those.
Okay. So yeah, we kind of categorize in modifiable, non-modifiable, right? So in the name, it kind of means we can change some of them in the modifiable group, and then the non-modifiable, we kind of stuck with those. You just have to recognize those risk factors. But for the modifiable, it's going to include the high blood pressure, hypertension, cholesterol trouble, and then I'm blanking on some right now.
Diabetes,
yeah, kidney disease, diabetes, exactly right. So those things, and then diet, obesity. So those are going to be our kind of big modifiable risk factors.
Yeah, and smoking maybe.
Right. Yeah. Definitely smoking. That's the number one risk factor for having cardiovascular disease. So anyone who smokes, you increase your risk for having a heart attack or stroke 4 times. So 400% increase just by smoking. So by far the best thing you can ever do for your health is going to be quitting smoking if you do smoke.
Absolutely, yeah, and some, I have my husband, his family, they have a lot of heart disease, that runs in that genetic risk, so that's something that you really can't change.
Yeah, unfortunately, can't pick our family, so we're kind of stuck with some of those genetic factors and stuff like that. So yeah, the non-modifiable ones are the ones that are going to be, family history. So we usually kind of look at the parents, and if they had some type of heart attack, heart problem in the 50s, we usually early 50s, definitely 40s, we think it's probably a genetic component to it. And then you have your siblings and stuff like that. So if they have, some type of heart attack history early in age, it's some probably genetic component to it. And then, gender, we can't really kind of change that either, right? So males will have a little higher risk, younger, and then females, they kind of catch up later after menopause because there's a little bit of protection that we get from the estrogen in the females.
Gotcha.
And then, usually, mostly there's going to be the genetic component of.
Yeah, and you bring up a good point that around 40s and 50s, if someone has an episode or a heart attack or something, if someone has a heart attack maybe later in life in their 60s or 70s, that's probably from their lifestyle, right?
Yeah, we all get some plaque buildup just going through life, living life. So, but it builds up quicker if you're smoking, bad diabetes, bad blood pressure. So yeah, it usually kind of catches up in the 50s if those things are not really well controlled. But everyone kind of has a grandpa who had their heart attack, right? And usually that kind of in the 50s, but everyone was smoking back then.
Right.
But yeah.
Interesting. Okay, so with reducing these risk factors, we are talking also about heart attacks, and there are some classic symptoms, but then there's also some symptoms that may be, you can just kind of shrug off as something like heartburn, So tell me those symptoms that we should really be looking out for.
Right. So the classic one is going to be that chest pain that, I feel like elephant is sitting on your chest, pressure like pain, tightness. So some type of chest discomfort people typically will have with a heart attack. Sometimes it will kind of go to the shoulders, radiate. We usually kind of say the left arm to the jaw. Those are kind of more your classic ones, but most people didn't read the textbook, so everyone's going to present a little bit differently.
Right.
So a lot of people also have like more indigestion, GERD symptoms and stuff like that, which they kind of put off a little bit more than they would if they had the actual chest pain. But those are going to be kind of your classic ones. And then, usually we kind of think females, especially kind of older, and if you have diabetes, kind of have that chest pain, you kind of get more of the nausea and some cold sweats, shortness of breath, lightheadedness. So if you have those associated symptoms, it kind of really raises the suspicion that you're having something wrong with the arteries in the heart or some type of heart chest pain.
Gotcha. Okay. Well, if you're just joining us, we are talking with Dr. Joseph Golden. So sorry, Golden with Willis Knight and Bossier Cardiology, and we were talking a lot about heart disease and specifically heart attack and reducing those risk factors and what are those symptoms to look out for. And if you have a question for Dr. Golden, you can give us a call at 318-219-4569. We'd love to hear from you. Maybe if you are currently having these symptoms and you're concerned, certainly you may want to visit your emergency room or, give us a call and we would be happy to talk with you through these questions. So we were also talking about, the symptoms that you would have, but sometimes let's say you go to the doctor and maybe you're having those slight symptoms. It's not like the elephant sitting on the chest. Could that also be an indication that you have some blockages going on?
Yeah, so heart attack is a little bit different from the stable blockages we kind of build up. So heart attack is when the artery suddenly goes down, and that's kind of when you get that sudden chest pain and not really going away. But if it's more of a cardiac chest pain, it can be progressive typically on a lot of patients if they have slow build up the arteries. So whenever the heart's working harder, that's when you typically would get the cardiac chest pain. So if you're on the treadmill exercising, you have to stop because of chest pain, trouble breathing, and it's pretty consistent. So it's not very random. It should be every time you're trying to work and do a little more exercise. Your heart's sending that oxygen. It's just not able to compensate, so you get chest pain.
Gotcha. Very interesting. Well, we have our first caller, and thanks for joining us. And what is your question?
Good afternoon. My question is, I'm a female in my 70s, and I suffer with onset shortness of breath, and it's progressed over the months to be more severe. It's to the point where I can't breathe, I can't do any activities, I have to get in bed and rest. I've had EKGs, nothing shows on the EKGs, and I would like to know what type of test would you run to find out where this shortness of breath is coming from.
Okay, thank you. That's a great question.
Yeah,
we see this all the time in clinic. Usually your primary care physician will kind of refer to cardiology. It's kind of the first stop because you want to rule out that the heart's causing the symptoms. And then you can focus on other things like the lungs or something else. But if it's something more of a big change and it's kind of suddenly happened over a couple months, it's something that you should kind of look into. And so EKGs typically won't show anything unless there's an old damage or you already had a heart attack when you see some evidence of that. But if you're having active chest pain, the heart attack, EKG can show it. So I'm not too surprised that the EKG doesn't show any change. Usually we think about kind of starting off with a stress test and looking at the blood flow in the arteries of the heart, and if there's any abnormality, we typically proceed with a stress test and a heart cath after that.
Did that answer your question, Anne?
Thank you.
All right, thank you. There's a little bit of a lag, but
okay.
So kind of talking about that, there's different tests that people can run if they're concerned. So EKG and then the stress test is also maybe diagnostic as well.
Yeah, when it's more of a stable chest pain, we usually kind of go the non-invasive route before going to straight to heart cath, depending on the symptoms, risk factors, and that type of thing. But yeah, so outpatient clinic, if we're seeing someone who's having new symptoms, definitely if it's kind of limiting their capacity to do things, we'll start off with typically a stress test. Usually, if they're younger, we like to do more of a structural evaluation, meaning we actually like to look at the arteries themselves. And there's CAT scans these days where we can actually look at the arteries themselves and see if there's actually any plaque buildup.
Okay, and that's something that maybe would be the next step in that. If they don't see it on the EKG, you could also do a CAT scan?
Yeah, either a CAT scan or a stress test.
Okay.
Younger patients we favor because it would change some of our management or how aggressive we want to be in the cholesterol management and stuff like that.
Gotcha.
Usually we expect some plaque buildup, just again aging and going through life. So the stress test itself gives us a functional assessment, meaning that we can actually see how it affects the blood flow going to the muscle and the heart. So that tells us a little different information, but those are kind of the two non-invasive tests we can do. Right,
and it kind of depends on the person, like you said, their age, maybe their risk factors, and that's something that you would talk about, in your consultation with them. Right. So, and with the realm of cardiology, do you have to have a referral from your primary care to establish care with you?
Yeah, I think it's more of an insurance issue, I think. Usually we require a referral from the primary care to set up the clinic appointment and all that stuff.
So if someone is having these symptoms, they could, go see their primary care and say, hey, I'm having these symptoms. I would, they could request a referral, I'm sure, or the primary care might see, oh, this is maybe, a good next step.
Right, yeah, exactly.
Okay, good deal. So, with heart attack, that's something that's very serious and it can be life-threatening, right? And it needs to kind of be addressed almost immediately. But how do you differentiate between heart attack symptoms? Would you rather a patient be safe than sorry, just go to the emergency room even if it isn't a heart attack? Yeah,
I mean, I guess, so definitely something's new and it's not going away. I think that's definitely where you kind of need to go to the ER. Again, we kind of see some patients who present, I waited all night and didn't go away. I was walking around and, finally my wife made me come in is what they'll say. And, but if it's something new, and lasting, not going away, go to the ER. But, of course, the again, we have a lot of things in the chest. It could be the lungs, it could be the esophagus, the stomach, those type of things as well. If it's something fleeting, a few seconds of pain, it's usually not heart. Usually heart is more of lasts for about 5 minutes. Yeah, and it may not be drastic per se, but it will last for, at least a couple of minutes, and it can come and go, but it's usually not like a few seconds, a little tinge or something like that. So.
Okay, gotcha. So you also help manage cholesterol, right? So I know that the lipid panel or your cholesterol panel can be a little confusing when interpreting it, or if someone knows that they have a high cholesterol, total cholesterol, but it also matters the type too. So you're bad and you're good. So take me through what someone should strive for with their lipid panel, and then how we can, then manage it if we want to decrease or increase those numbers.
So, of course, diet and exercise always plays a role in the cholesterol management. But when we do a lipid panel, we'll get, the total cholesterol, the triglycerides, an LDL level, and an HDL level. So we get all those values. And so the bad cholesterol is that LDL, the low density lipoprotein. And so that's the one that we kind of increases your risk for having heart attacks, strokes, and stuff down the line. The HDL, the high density one, is the protective one. So usually strive to have the HDL above 50, the LDL below 100. And then it depends a lot on the patient about what we can do. Sometimes we'll just suggest lifestyle management changes. Depending on what the level is, sometimes we can't really get the LDL where we want it to be to kind of reduce the overall risk. It's more about long-term exposure to that LDL. So someone with an LDL of 120 is going to have something earlier than a patient with an LDL of 60. So if you get a little statin medicine and kind of reduce that long-term exposure to the LDL, it would be beneficial. But yeah, a lot of different kind of factors that would play in like how we manage the patient per se.
Okay, well, we have Mary on the line. Mary, what is your question for Dr. Golden?
My question is every time I go to the emergency room at the hospital, they say I have AFib, but yet my doctor says he doesn't think I do. But the emergency room and the doctors at the hospital say I do.
Okay.
So what is AFib?
So AFib, it's a pretty common rhythm we'll kind of see. It's actually, it's about 1 in 4 patients will actually have AFib, just by age. So above 70, 1 in 4 patients will kind of have AFib. But it's an abnormal heart rhythm. The heart's supposed to beat in a very organized pattern. So it's supposed to be top chambers, bottom chambers, top chambers, bottom chambers. AFib is when the top chamber is fibrillating, so it's not kind of going haywire. So it's not pumping and squeezing like it's supposed to. And we concern ourselves with 2 things really, kind of the rate control and then preventing the risk for you having a stroke from the AFib itself. And so I'm not too sure. I would have to kind of look at the EKGs and stuff like that. The other question is, I'm not sure if your primary and your ER are in the same system, because not all systems kind of can communicate. I'm saying, like, if a patient went to Christus, I can't really look at their EKG easily. I would have to request records and that kind of thing. But there's some other heart rhythm stuff that can kind of look like AFib but not be AFib. It, again, kind of depends on a lot of different things. But I think if you're having a question, it's appropriate to probably see a cardiologist. You have them to kind of look at the EKGs themselves. Did that answer your question?
Yes, it does. Thank you very much.
Okay. Thank
Thanks,
you.
Mary. Yeah, and if you're just joining us and you have a question for Dr. Golden, send us, or you can call us at 318-219-4569. I almost said send us an email. Calling would be much better. So give us a call. That number is right there on your screen. So, regular heart screenings are really important, but, who is a candidate for, is it really anyone that should, check in on their heart, or is it more people that you think are at risk, or does it apply to everyone?
I think it applies to everyone.
Yeah.
So again, the goal when you see a primary care doctor is to prevent stuff. It's not to kind of get stuff after it happens, because after the stroke you already kind of had some problems, and then after the heart attack you have problems. So the goal is to prevent the heart attack from happening, to avoid the heart failure and other kind of things that go along with it. So routine screenings are very important. I think especially as we kind of go through age, you should be seeing your doctor at least yearly. And that includes kind of checking your cholesterol. Mainly blood pressure is a big one. We call that the silent killer, because most patients won't know they have high blood pressure, until they have to come in with a heart attack or the kidney disease or the stroke.
Right.
So, that long-term high blood pressure, you want to get it controlled early to prevent the stuff from happening later down the line. So definitely seeing your primary care doctor yearly, making sure blood pressure is well controlled, not diabetic, glucose check, lipid panel. You don't have to do it every year, but at least having a screening here and there.
Yeah.
And exercise and all the other kind of risk factors that go along with heart disease and stroke risk
And
factors.
that's a good point, because with heart disease, I think it's kind of a chronic condition, right? That some people, or the plaque buildup is chronic condition. And like the silent killer that you mentioned with blood pressure, but then also plaque buildup, it's not like you can feel your arteries clogging with plaque as you eat your meals over time. So it's important to just have those baseline checks for sure.
Right, yeah, exactly. So yeah, you usually won't notice the plaque buildup until you start having, more of those exertional chest pains and trouble breathing. Then that's when it kind of, got to a point where your body can't really compensate. So
yeah. So let's talk about blood pressure for a second. So can you tell me or explain how, an increased blood pressure will cause damage to, I guess, is it your arteries, your blood vessels? Right.
So yeah, just high blood pressure itself, it kind of damages the lining of the vessels and leads to kind of plaque buildup itself. So, and not to mention the heart's pumping against that pressure, so it kind of wears out the heart too. So, it's a very common reason for just having heart failure is just from the high blood pressure, because your heart's been pumping against that pressure for so long, it wears out. So, it's been kind of running a marathon basically. But yeah, kind of the pressure against the heart itself, and then the risk for stroke, and then the plaque buildup. But yeah, all those things kind of play a role with the high blood pressure.
Gotcha. Okay. And cardiovascular exercises or aerobic training, how does that benefit your heart or reduce your risk for heart disease?
So currently, our American College of Cardiology and the American Heart Association, they recommend that we get aerobic exercise weekly. They kind of say 150 minutes per week, which comes down to about 30 minutes, 5 days a week. Okay, that's what I tell my patients to walk 30 minutes, I'd say every day. I'll be happy, hopefully they at least do 5 days.
Right.
That would be kind of the goal of exercise you get. So it helps out pretty much everything. Every study's kind of shown some benefit of just daily exercise. Our bodies aren't really made to kind of just sit around and not do anything. We're made to keep active, we're made to kind of walk around. It kind of helps your heart stay active and healthy, helps the blood flow. And then it helps the cholesterol itself too. So even if you don't lose the weight with exercise, the cholesterol goes down, the blood pressure goes down with just a daily exercise. So if people can incorporate that in their lifestyle, it's important. The other thing I'll see too is that, I walk all day and at work or something like this, and so they won't do that dedicated exercise. But I think it's important to just have dedicated exercise where you just focus on exercise. Understand if you're active and doing a lot of it work, but having that exercise itself, I think, helps with the mindfulness and overall health too. So
yeah, and I think a lot of times I forget that our heart is a muscle. And if you don't, work out if you're trying to get some big biceps or something, you don't work it out, then it's not going to happen. But if, same thing with your heart, if you don't work it out, then it's not really great for its longevity, right? So, that's a good point too. So there was something else I was going to say, but I don't remember. So we'll just move on. So smoking is, a really big risk factor for heart disease. So is it because of the nicotine that's in a cigarette, or the things that most people, is it the nicotine that is what's
driving everything?
Yeah.
It's going to be probably a lot of different factors. So it's not just the nicotine, it's the chemicals they put into it too. And so, of course, you're kind of smoking goes into the lung and then into the body. So it's not really using that normal kind of system where, it's filtered by the liver and stuff like that. So all those chemicals are going in the body. They basically cause irritation and inflammation of the artery lining, which causes the plaque to kind of build up. So inflammation and inflammation of the artery lining will cause the plaque to kind of build up. So I mentioned earlier, again, huge risk factor. So, other things like cholesterol, hypertension, obesity, all that stuff plays a role, but then smoking is way up here for your risk factor for having, issues down the line with a stroke and mainly the high blood pressure. So about, again, a 4 times increase in having heart attack and stroke just by smoking itself. And so, unfortunately, it's not a medicine that will reduce your risk for having issues as much as just quitting that tobacco, the smoking. And the nicotine, also is it kind of stimulates the heart. That's why you get the energy from the nicotine. So it causes your arteries to kind of clamp down, increases your blood pressure, increases the heart rate. So nicotine chemical itself also plays a lot of role in issues we see with the smoking.
Gotcha. Yeah. So definitely, participating in some kind of smoking cessation program, if it is difficult to quit, because it is, but definitely the benefits far outweigh the detriments with smoking for sure. So
right. And so I encourage patients to talk to their primary care providers. And biggest thing too is picking a day to quit. Otherwise, we keep pushing it off. So I usually kind of pick a holiday or a birthday or something with my patients, and that way they're kind of held accountable. So I encourage anyone, if they're thinking about quitting smoking, pick a day, let your family know. That way they can bug you about quitting. Otherwise, we keep pushing it down the line. And not to mention, it's very expensive today too.
Right. Yeah. Well, now I'm going to pick on my father-in-law real quick, but he had a heart attack and. Several years ago, but he was a long-time smoker, and he, asked God help me to quit. And the next day he had a heart attack. So it's just, that was his sign. So so he was like, all right, it hasn't smoked since.
Oh,
so,
good. I thought you were about to say he started smoking again.
No,
We have to
no.
pick up the quit day for him. No.
So that was an answered prayer for sure. But yes, smoking is definitely one of those big ones. And I remember what I was going to say earlier about exercise. Working out your heart is really important, but it also can help reduce stress, right? So,
yeah.
and how big is stress? Stress's impact on your heart and your chance for heart disease.
Right. So I don't think there's like it's going to be hard to kind of measure stress.
Right.
So it's kind of hard to say, but of course it plays a role in everything. So, stress, of course, causes a lot of hormone changes in the body, and, blood pressure goes up, and so it has a lot of, negative health factors that play a role. Unfortunately, you can't really manage stress a lot. I mean, you can't change your stress level. So it's one thing we see with people trying to quit smoking. It's like, oh, I can't because I'm too stressed. But, life, we always want to have some type of stress in it. So you have to find productive ways to kind of deal with it. So, yoga itself has been shown to be really beneficial for a lot of cardiovascular health. So that's a good way if you can get into yoga. But again, daily exercise or some productive way of dealing with stress is, of course, important. So
right, yeah, and I think it goes back to heart disease is just multifaceted. There's so many different things, so you want to try to manage it in all these different ways. So can exercise also increase your HDL or your good cholesterol? Is that one of the benefits as well?
Yeah. So it's kind of, people get different changes and stuff like that. So of course diet and exercise will help out the cholesterol numbers themselves.
Yeah.
They say if you're kind of perfect with all this stuff, you can maybe get like a 20% decrease and stuff like that. So it kind of depends where that level is, but that's diet and exercise itself. But yeah, it definitely will help raise that good cholesterol, the HDL, and then lower that bad cholesterol, the LDL.
Okay, good deal. Okay, so let's say someone found with a CT scan or a stress test that they have a couple of blockages. Would the next step then be a heart cath?
Yeah, it depends on kind of their symptoms and stuff like that. Medicines they're trying out to be really good these days. So sometimes we don't always try to stent everything. It kind of depends on how patients respond to the medicines, and then how bad their symptoms are, and then where the blockage is, though, is important as well. So, if it's a small artery, it's not as important as, your the Widowmaker and some other ones like that. So we usually favor kind of fixing those ones, rather than just doing medicine. So, the location and then also the symptoms play a big role.
Yeah, and does it also depend on how much that artery is blocked? Like, let's say it's like 80% blockage versus a 30% or something.
Yeah, yes, exactly. So we typically don't fix anything unless it's at least 70% or above. Okay. And so that's kind of our cutoff there. So at least that amount you would have to consider for fixing it. But yeah, if it's about anywhere between the 10 to the 70 range, it's usually kind of the medicines, risk factor control, because the goal is to keep them from growing too. So if you're still smoking, if you still have bad cholesterol, high blood pressure, it's going to keep growing, and our goal is to keep it stable and not growing. So
yeah, and maybe decreasing inflammation as much as possible, whether that's through managing, I guess, the diabetes or the stress or the diet, so that's important for sure. So you mentioned are you accepting patients right now?
Yes, I'm accepting patients, yeah.
Great, good deal. So if someone is interested in, maybe I really need to get my annual heart screening checked out, is that something that you could handle as well?
Yeah, I'll be more than happy to see anyone who will come to clinic. So yeah, I encourage anyone, especially if they're having symptoms like that first call, or definitely would be beneficial to see a cardiologist. So yeah.
Okay, and so they could maybe go to their primary care and say, hey, and they can ask, which provider, so they could say, can you refer me to Dr. Golden? Okay.
Yeah, so on the referrals we get, that's primary care can request a certain provider or any of that stuff, or they can call a clinic too. That's of course, and then we usually ask them to send a referral from the PCP. But
easy enough. Okay, so what is your clinic phone number?
So actually,
because
I'm terrible. I'm terrible at remembering the numbers. Oh no, I lost it. Here it is. So our clinic number is 318-752-2328.
752-2328.
Yes.
All right, easy enough. And you're located where? Willis-Knighton, Bossier?
Yeah, that's where I'm primarily located. That's where my clinic is, at least, too.
Okay, well, if you are interested, Dr. Joseph Golden with Willis-Knighton Bossier Cardiology, thanks for joining us. And if you missed this will be on our website at ktbs.com/podcast. Thanks for joining us.